think I go next. So I'm going to quickly share my screen. Okay. Yeah, I know it's not full screen share, but I prefer it this way because otherwise I lose all my Zoom controls and then I don't know where I am. So I kind of prefer it this way. Thank you everyone, for joining. Welcome to the second STARR Informatics Summit. I am Priya Desai and I'm the product manager and product owner for STARR. I am super excited that we could actually host this summit again. So thank you for being here to celebrate the vision, the accomplishments and our journey so far. So for the benefit of our new users, and I know we have quite a few of them, I just wanted to spend a couple of minutes talking about why STARR and how does this fit into the larger School of Medicine ecosystem. So Stanford School of Medicine's mission statement is to educate and inspire leaders in medicine and science who will improve human health through discovery, innovation, education, and the delivery of outstanding patient care. So to get there, we need outstanding leaders, scientists, and doctors, all of which we have. But we also need data, good quality, reliable data. And that is where STARR comes in. So as Nigam's already alluded to, today's digital era with AI and ML becoming more mainstream, multimodal data-driven approaches have emerged as an important driving force for smart healthcare systems. They have applications in many areas, ranging from disease analysis to triage, diagnosis, treatment, and better patient care. So in 2016, the vision for a new significantly expanded data lake, STARR, which stands for Stanford Medicine Research Data Repository, was born, with the goal to host multiple linked analytical data warehouses containing a range of different data types, all in one place on the cloud. Historically, a lot of this data has existed in silos. So the vision for STARR was to really break down these silos and create a single integrated data lake containing clinical data of different modalities. So to bring clinical data from its raw state to an analysis-ready state, and eventually to make much of this data self-service. So STARR contains both structured and unstructured, raw and analysis-ready data. So today, STARR can be thought of as having four main components. On the top left teal quadrant, sector, you can see that STARR has raw data of different clinical modalities. As Nigam was alluding to, a lot of the data that is in STARR is still in the raw form. For example, it contains the EPIC Clarity EHR data from both hospitals and associated clinics. It contains radiology images, including MRIs, X-rays, CTs, and ultrasounds, also from both hospitals. Bedside monitoring data from the Children's Hospital, echocardio data from both hospitals have also been brought in, and we're continuously working to add in more data types. The bottom left purple sector shows the analysis-ready data. STARR currently supports two data models for EHR data. We continue to support the legacy data model, which was formerly known as STRIDE, as well as the OMAP common data model. The red sector on the top right shows the self-service tools that are supported by STARR, including the new one ACE. And the yellow sector on the bottom right is for the services that are offered by the STARR team. So this includes the data vending team at the Research Informatics Center, as well as working with experts in the ODC consortium to improve our data quality for STARR OMAP. So next, I'd like to just briefly highlight some of our achievements thus far and projects underway. This is a slide from last year's summit, and I think it gives a really nice snapshot of the progress that we've made since the work on STARR started. So though the vision for STARR was first conceptualized in 2016, it was 2018 before the pieces really started falling into place. And here's a timeline of some of the major milestones, including the development of the image de-identification pipeline, integration of radiology data from both hospitals into STARR, bringing in the bedside monitoring data, and so on. In 2018, Nero, which is Stanford's secure HIPAA compliant big data computing platform, went live. And in 2019, we actually converted the EHR data from both our hospitals and clinics and affiliated clinics into the OMOP common data model. So our OMOP is refreshed and updated weekly. All Stanford researchers can access the de-identified OMOP data pre-IRB. Our OMOP data set includes de-identified clinical notes and can be accessed via Nero. We've sort of continued to expand STARR, and I wanted to highlight some key achievements of the past year. So this past year, one of the big projects that we undertook, it was a big infrastructure project, re-architecting our Clarity database. So historically, we had a pretty complicated workflow of getting, say, the hospital Clarity data for research. And this involved nightly incremental updates, a pretty fragile setup that was sort of hard to debug, often resulting in incomplete data. But now, as a consequence of this replatforming, STARR has a complete copy of the hospital Clarity data. This data is refreshed every day, and we have reduced the latency to the hospital Clarity down to about 12 hours. The data is consistent, stable, and reliable with high fidelity. So we believe that the days of data outages when our ETLs would go stale for a couple of months at a time are a thing of the past, hopefully, fingers crossed. Additionally, we've continued to work on expanding the legacy data model, which was formerly known as STRIDE. The beloved cohort and chart review tools have now been migrated to the cloud. So this makes things a lot easier at the back end. But for you, the user, this means better quality data, and that complex cohort queries now run an order of magnitude faster than they did before. We've also added a user-requested feature whereby you can now constrain your new cohort searches to be limited to previously saved cohorts. And you feel free to attend the afternoon workshop to actually learn more. Finally, we have also restored the Social Security Administration death data feed. This SSA data, death data, accounts for over 70% of the mortality-related information, including the death dates that are available in the legacy data model. And we are in the process of trying to integrate this with STARR OMOP as well. One of our other priorities continues to be enhancing the STARR OMOP data tables. So some of the changes this year include populating the payer plan table for all patients from the Stanford Adult Hospital. So this table basically will contain the payer plan name, the benefit plan type, so the financial class, and the period of coverage. So this will allow researchers to examine correlation between insurance coverage and healthcare utilization, and it'll be available pretty soon. Geocoded data is also now available for all Stanford patients. This location information includes latitude and longitude data, census tract and census group data, and will enable easy linkage to public data sets on pollution, air quality, socioeconomic status, etc. So it will really allow linkage of, linking the electronic health records systems with the community information systems, and thereby really support, research on social determinants of health. Just caveat, note that latitude, longitude, census tract, census group, all of this is PHI, so you will need an IRB. Finally, we've also made data quality improvements, such as the inclusion of primary diagnosis in the condition occurrence table and clearer distinctions between labs and procedures, which we believe will help in better cohort creation. We've also added support for the following data types, like hemodynamics and blood transfusion, and you can now request these data types from our data vending team, Rick. On the self-service tools side, we have actually expanded the availability of another self-service tool, the Advanced Cohort Engine, or ACE. It's now available to all Stanford researchers. ACE runs on the DID STARR OMOP data and has native support for complex temporal search and is blazingly fast. Again, please attend the afternoon workshop on ACE to find out more. We've also been more active in the community and are now part of several consortia and networks. Noteworthy among them is PEDSnet. PEDSnet is a multi-specialty pediatric clinical data research network using the PEDSnet common data model. So LPCH data is now available to all pediatric researchers at Stanford, and it's in the PEDSnet common data model. The STARR OMOP DID data is available for instructional use at Stanford. So I wanted to call out to all course instructors. If you're looking for a clinical data to use in your classes, we have one right here. Many of you completed our Getting from Good to Great survey, so thank you. There were some strong themes that emerged from that, and then what we've done is we folded that feedback back into our roadmap for the next year. So one of the overarching themes was data quality, and in the coming year, we do plan to spend time on improving our mapping rates, especially the procedure and measurement table mapping rates in the OMOP CDM. As mentioned before, we are planning to integrate the Social Security Administration death data in STARR OMOP, but we're also hoping to be able to bring in the California public use death data for the adult system, for the adult hospitals. Two other STARR projects that have been scoped out and are on the plans for next year are self-service access to the OMOP data and the modernization of real-time research alerts. So here are some links to some of the main STARR resources, including STARR support services, many of whom you will meet this afternoon in the breakout rooms. These slides will be made available so you can access all these resources easily. But I wanted to end with a big shout out to our leadership, our business partners and collaborators, and of course, the amazing technology and digital solutions team without whom none of this would have been possible. To you, our users, thank you for your support, and we look forward to continuing the STARR journey with you. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.